In the event of an emergency, please remain calm, walk, do not run to the nearest exit. Emergency exits are located at the front and rear of the hall. Please look around you and note the location of the exit nearest you. It may not be the same way that you entered the hall. Smoking is not permitted inside any university building. This program is being webcast. To maintain the quality of the feed, we need to limit movement in the room. If you need to exit during the program, you will be directed to the back of the hall. Please silence your cell phones. Food and drink are not permitted inside of Somer Hall. Thank you for your attention and cooperation. The program will about to begin.
Ladies and gentlemen, and honored guests here in Baltimore, and online viewers around the world, good morning and welcome. I'm Ellen McKenzie. I'm Dean of the Johns Hopkins Bloomberg School of Public Health. I'd like to start by extending a special welcome to President Bill Clinton, who you'll hear from in just a few minutes. Also joining us today are several policymakers leading the way in health reform. They include Congressman Elijah Cummings and Baltimore City Health Commissioner Dr. Leana Wen, both of whom will be joining us here in the program. Also in the audience are Congressman John Sarbanes, Maryland Delegate Antonio Hayes, and representation from Senator Ben Cardin's office. Finally, I'd like to extend an especially warm welcome to Senator Barbara Mikulski, whom we are now proud to call one of our own. Thank you so much for being here. We are indeed honored to be working with the Clinton Foundation to bring you today's summit on one of our most important public health problems, America's opioid epidemic. This is a national crisis that demands involvement from all levels of government, public and private organizations, as well as from individual citizens. Every day, nearly 100 die from opioid overdose. Over the past 15 years, the death rate from opioid overdose has tripled. The causes are complex. Millions with chronic, non-cancer pain are prescribed opioids instead of safer, less addictive alternatives. Heroin is more available and increasingly contaminated with illicit fentanyl. And far too few people have access to evidence-based addiction treatment. The Bloomberg School's leadership in preventing and treating substance use disorders stretches back nearly 50 years when we founded the nation's first graduate training program for drug and alcohol counseling and advocated for the adoption of methadone in federally funded treatment programs. That leadership has since been cemented in the founding of two centers, one for injury prevention and control and the other for drug safety and effectiveness. Our collaboration with the Clinton Foundation to address the opioid crisis began in May of 2014 when President Bill Clinton led a town hall in this very room focused on the rising rates of injuries and deaths from prescription opioids. The resulting synergy united national leaders from academia, government, and the private sector and paved the way for a year-long effort to synthesize efforts and identify best practices. Based on this initial engagement, in 2015, the Bloomberg School and the Clinton Foundation produced a document that had identified a path forward and framed the problem as a severe public health issue. This document called for scaling up existing evidence-based interventions to prevent future loss of life. Despite such efforts, however, we still have a long ways to go. Opioid deaths reach an all-time high in 2016, and the numbers just keep rising. And despite recent announcements by the White House, our country has not yet addressed the real need for urgent action and a true commitment of resources. A new report just released by the Bloomberg School and the Clinton Foundation, entitled The Opioid Epidemic: From Evidence to Impact, describes 10 pillars to address this complex epidemic now, including implementing prescribing guidelines, optimizing prescription drug monitoring programs, advancing engineering solutions, as well as combating stigma. These strategies work. They have been shown to work. And today you'll hear from experts and advocates working together to change the course of the epidemic by further developing and implementing these strategies and generating new evidence. But we need your help. Please, let's work together to stop this deadly epidemic. I'm honored now to introduce Congressman Elijah Cummings. Born and raised in Baltimore, Congressman Cummings has represented Maryland's 7th Congressional District since 1996. He is the ranking minority member of the House Committee on Oversight and Government Reform and serves on the Task Force on Health Care Reform. As co-founder and chair of the Congressional Caucus on Drug Policy, he has helped shape national policy on drug addiction, illicit drug trafficking, and access to affordable medications. Please join me in giving a warm welcome to Congressman Elijah Cummings.
Good morning, everyone. Come on, we can do better than that. Good morning, everyone.
Good morning.
It is certainly my honor and my privilege to be here. And I want to thank you, Dean McKenzie, for your very, very kind words. But more importantly, I thank you for your work. I must take this moment. I have to do this. On behalf of my family, and certainly on behalf of generations of Cummings yet unborn, I want to thank Johns Hopkins for taking good care of me. Having spent almost 2 months in the hospital just a few blocks from here after a heart procedure, I must say that I have grown to love Johns Hopkins even more. And so to Dr. Resard, to Dr. Sisson and staff, to the cleaning people, to the cafeteria folks, everybody, Lottie Dottie and everybody associated with this campus, I thank you for changing the trajectory of my destiny. I truly, truly appreciate it. Thank you. So I'm honored to join former President Clinton and Dean McKenzie in welcoming our distinguished panel to this third summit on our nation's opioid crisis. It's certainly always good to see my good friend, my mentor, and I will always call her my senator, Senator Mikulski. And I understand that John Sarbanes is in the room. Congressman Carl Sarbanes, I'm glad that you are here too. The danger that we now face and must overcome is more virulent now than ever. Prescription opioids, heroin, fentanyl, and other synthetic drugs were involved in more than 60% of overdoses last year that resulted in 64,000 deaths. Let that sink in. 64,000 deaths. Here in Maryland, at least 2,089 people fatally overdosed in 2016, up 66% from 2015. This is stark evidence of how these dangers and human devastation are expanding exponentially. There's a bipartisan acknowledgement that a national public health emergency crisis does exist, but resistance remains in both the White House and Congress to taking bold action. Earlier this year, the President's own opioid commission, led by Governor Chris Christie, recommended that the President declare a national emergency. As all of you know, last week the President declared a public health emergency, which is a good first step, but does not unlock any additional federal funding to confront this crisis head-on. The Christie Commission also recommended something else, that the President authorize the Secretary of HHS to negotiate lower prices for naloxone, the life-saving drug that reverses the effects of opioid overdoses. And I'm sure you'll hear a lot more about that from Dr. Nguyen, who has been a staunch advocate of making sure we expand its usage. Right now, our people on the front lines of this epidemic cannot afford to stock up on naloxone. That's why last month I led 50 House members in sending a letter to President Trump asking him to adopt this recommendation. We didn't ask him, we begged him. Unfortunately, the President didn't even mention the word naloxone in his announcement last week. Finally, as you all know, the President and the congressional Republicans have spent years trying to repeal the Affordable Care Act and reverse the Medicaid expansion, even though Medicaid provides treatment services to 3 in 10 people who struggle with opioid addiction. If we are going to respond to this epidemic, we need your evidence-based research and your continued active engagement in the public debate. We must encourage the President to follow his own Commission's recommendation to expand the availability of naloxone and reduce the cost. We must press insurance companies, listen to this, we must press insurance companies to eliminate their bias in favor of opioid-based painkillers, and we must challenge our friends in Congress to expand public health funding, preserve Medicare, and safeguard Medicaid. Finally, let me say this. You already know that our response to this public health crisis is a test for our community. It is also a test for our entire society. My good friend from Maryland, Congressman John Delaney, has an expression that applies directly to the current crisis. And you know, it's one of those expressions that you hear something, you say, I wish I had invented that. I wish I had come up with that. But it's so true. And Senator Mikulski, I think about this all the time, these words, because they're so true. He says, the cost of doing nothing is not nothing. Tweet that. The cost, think about it though. The cost of doing nothing is not nothing. And so let me repeat it, the cost of doing nothing is not nothing. And we've seen it over and over and over again. And so, ladies and gentlemen, I thank all of you for being here today. We are an army, and we are going to fight, and we will overcome. Thank you very much.
Well, thank you very much, Congressman Cummings, for your leadership on this issue in Congress and those inspiring words for us today. I am now thrilled to introduce and welcome back to our school President Bill Clinton, founder and board chair of the Clinton Foundation and 42nd President of the United States. After leaving the White House in 2001, President Clinton established the Clinton Foundation to build more resilient communities by improving global health, strengthening local communities, and protecting the environment. In 2002, he launched the Foundation's initiative to negotiate prices for HIV/AIDS medications to extend access to 11.5 million people in over 70 countries, an achievement that many thought was impossible. Using a similar strategy, President Clinton negotiated national partnerships with 2 pharmaceutical companies to provide a predictable, affordable supply of naloxone to community groups, public safety organizations, and schools and universities. His goal, to cut prescription drug abuse deaths in half over the next 5 years, saving approximately 10,000 lives. This would be done through strategic partnerships that raise consumer and public awareness, advance business practice change, and very importantly, mobilize communities. Please join me in giving a warm welcome to President Bill Clinton.
Thank you very much. Thank you. Thank you very much. First of all, Dean McKenzie, thanks for having us back at the Bloomberg School of Public Health and for the ongoing partnership we've had in confronting the opioid epidemic. I want to thank Congressman Cummings for his remarks and his leadership on this and many other issues. He said that Senator Mikulski was his role model, and he certainly proved it in the last couple of years. When Barbara was a senator from Maryland, she was on a very short list we kept at the White House. It was called the Just Say Yes list. Because when she asked for something, you knew sooner or later you were going to cave in, because she was like a dog biting your leg. And so I said, look, let's save a lot of time. Just figure out what she wants and say yes, and we'll be able to go back to work. I'm glad to see her here. I'm glad she's teaching here. I want to say thanks to 2 other people for their inspiration to me in public health. One is Mike Bloomberg for funding this effort. He's got a lot of money, I know, but he could have done other things with it. And he was a great public health mayor of New York, and this is a great school. The other person I want to thank with our foundation who's not here is my daughter, Chelsea, who teaches public health at Columbia and is sort of my family in-house free expert on anything that relates to public health policy, and who urged me for years to get involved in this when most people weren't paying any attention to it. I want to thank mostly all of you for being here and agreeing to take action. The CDC's latest provisional data says that in 2016, more than 64,000 people in this country died of drug overdoses. Well over half of them opioid related. If this data is confirmed, and we have no reason to believe it won't be, that means last year more people died of opioid-related drug overdoses than the numbers of deaths from the AIDS crisis at the peak before it was treated, than from gun-related homicides or from automobile accidents. Opioid-related deaths are now the leading cause of death for Americans under the age of 50. Virtually all of us know someone in a family that has lost a loved one. Hillary and I have 5 friends who've lost their children. And I've learned a great deal from these families. One of them had a son who was working for Hillary when he died and had worked for me and was in the law and MBA program at George Washington University. He was a very smart man, but nobody ever told him you couldn't pop a pill to get a buzz after drinking 5 beers and go to sleep, or you might never wake up. Everybody's got stories like that. And now, as we know, the epidemic has grown like wildfire in small towns and rural areas with no public health infrastructure, where people don't know what to do or can't do it if they know. It's not only a human tragedy. The CDC estimates it costs us more than $78 billion a year to continue to do so little in such a fractured way on this problem. Healthcare costs, criminal justice-related costs, addiction treatment, lost productivity. Yet for all the noise that's been made about it, and the genuine legitimate concern, and the extraordinary efforts being made by people with nothing, and I mean nothing. I was in Chillicothe, Ohio, about 1.5 years ago, little town in southwest Ohio. And I was very proud of looking at it because it was totally rebuilt. It was an early 19th century town. All of the beautiful buildings were renovated because of investments secured partly under the New Markets Tax Credit, which was the last completely bipartisan initiative I signed to get people to invest in small towns and rural areas with high unemployment and low per capita income. That was the good news. The good news further was that the most beautiful building in town had been given over by the city to doctors who voluntarily came there so they could practice in Appalachia. Oh, it was beautiful. There was a doctor born in Poland who got her medical degree in New York who was living in one of those lovely apartments. But I walked out, and across the street, this woman is waving frantically at me. Please come over here. So I go over, and she said, I only own one asset of any value, a used car. I sold it and rented that office, and what you're seeing is the only drug treatment facility we've got in this town. She then introduced me to a woman whose husband had just died of a heroin overdose, the poor man's version of opioid addiction as we traveled down, and 3 women who were recovering heroin addicts. And she said, look, I'm happy to do this. I know nothing about it. I get whatever help I can, and it's all we got. I'm glad that one of our panelists is the head of public health in Baltimore, which had the first public health program of any city in the United States, going back to the late 18th century. But in many places, community health networks have been allowed to atrophy or never expanded to embrace this mission. This is like a good news, bad news story to me. The good news is this is the first drug epidemic when we act like a grown-up country and we're treating it like a public health problem instead of primarily a criminal justice problem. Some cynics, it's a good thing. Some cynics have said that's because it started among small town and rural white people at epidemic phases before it spread to the cities. There may be something to that. But I think the more likely explanation is that this is the first epidemic we've had killing this many people that had a non-violent delivery chain. Now, the problem is, as we all know, the more we get into cheap heroin grown into the Sierra Madre in Mexico, harvested by preteens, and fentanyl, the more likely we are to see more violent delivery systems as people fight over tough for guaranteed money. So it's coming to this movie is coming to a theater near you, whoever you are, whatever your color is, whatever your politics are. And so that brings me to the bad news. It's a public health problem. We've recognized it. Good for us. We're growing up as a country. We're seeing all these people as people. The bad news is there's a woefully inadequate public health response that is not properly coordinated with law enforcement, with the treatment community, with the insurers, with you name it. So what we're here to do today is to figure out what to do next. The next panel after ours, what we're going to try to do is identify what many of you already know, but the general public may not, which is where are we right now? What's being done that's good? What are the gaps? Then we go to the second panel, and our panelists are here. They're going to discuss the report we're releasing today, the Clinton Health Matters Initiative, along with the Bloomberg School, called From Evidence to Impact, which is a sort of professional way of saying we know what the heck is wrong, we know what we need to do, how about we do something? There are proven recommendations in this report for combating the epidemic, from allowing physicians to effectively treat those from suffering from addiction much better than some of them are allowed to now because of all the barriers you know, to expanding coverage and accessibility of proven helps like naloxone, to changing the way healthcare professionals, employers, and advocates actually talk about addiction so that we can reduce stigma and get people out of the closet quicker, because it's a terrible, terrible problem. We've been working on this since 2012, as Dean McKenzie told you. We've made some good progress. I especially want to thank Adapt Pharma for offering to give free packages of naloxone to every college campus that registers with them online, and to get them to every high school in America as they can with their limited production. They've been great partners. I think improving access to naloxone is still important. I know there are even debates about that. All I know is that we got a lot of people dying of drug overdoses, and most of them are still opioid related. And if you can save a life, you ought to do it. So I want to just briefly say 3 things we're going to do from here forward, and then bring the panel up. First of all, we've known for a long time that stigma plays a major role in preventing individuals and families from seeking treatment or accessing prevention sources. So in partnership with Facing Addiction, CHMI will launch a communication strategy designed to tell these people to get over it. Now, the proper public health word is to empower them. But once you've known a couple of people who lost their kids, I think we should dispense with the niceties. This is nothing to be ashamed of. It's a problem. It's a health problem. And we have to hammer that. And employers need to hammer it. They need to say, no, you won't lose your job unless you're too bullheaded to get help to save your life, save your family, save your kids' future. We need the same message to go out everywhere in a very straightforward way. Second, we've known that law enforcement, and Chief, thank you for being here and for what you have done. Criminal justice and addiction and dependency experts share similar goals, but they don't coordinate as much as they should. They don't cooperate. We don't have one simple, comprehensive strategy, even in places where you could take the money now being spent and spend it more effectively. So we're going to work with the Vera Institute of Justice to reduce opioid overdoses. by people who come in contact with the criminal justice system, by having more simultaneous contact with everybody else who can play a role in this. And finally, our community health initiative works in several counties in America today, in communities. We have learned that what we thought we were doing when I started this, I thought we were going to go into all these places and they'd say, biggest public health problem we've got before the opioid issue blew up on us is childhood obesity. Please come in and help us. But we said that first we would ask the people there. And it turns out, like Jacksonville, where I'm going, when I leave you, has the third highest rate of deaths of pedestrians by drivers in America. Did you know that? Because it's a city-county government, so you're in the city proper, like you're in Baltimore, and all of a sudden you're still in the city limits, and you're in the country, and you literally drive and you don't notice it unless you're just used to living there. So if you walk across a certain line, you may confront a car driving 60 miles an hour. So the point is we had to adjust this strategy in all these communities. But everywhere they say we need help with this. So we're going to do more than we have done to build up coalitions of stakeholders. Every other issue, we're getting everybody involved to fight together. And we can't let this one alone. I'll just give you one example, and I'll introduce her more effectively in a moment, but Randy Weingarten's on this panel, and the American Federation of Teachers also represents, I think, almost 40,000, a lot of nurses anyway. And kids are in school. So this summer, I'll never forget this as long as I live. This summer, Hillary and we go out normally to Long Island, as far out on the island as we can get, and find some place so our grandkids will come play with us in our dotage. And our daughter and son-in-law come, and we have a good time. And I try once a summer to go out to this wonderful old public golf course called Montauk Downs. It used to be a raceway in the 20s. And it's still a great old course. And there's all kinds of people there, you know, ordinary people that aren't rolling in dough have to come. And so afterward, I get off the course, and about 40 or 50 people just appear. And they start talking to me about various things, some of which you would guess. But it didn't take long to get to this. And we're talking, and it literally took me 40 minutes to get away from them. They want to know what were we doing, what was other people doing, what could be done in the community. And most of these people were from Long Island, but a lot of them were from elsewhere too. They were desperate. And there was one really good-looking young guy with big eyes, and his eyes kept getting bigger during the discussion. I'd say he was 19 years old maybe. And everybody walked away but him. I said, I got to go. And he said, I want to thank you for doing this. He said, I just got out of rehab. And I didn't think anybody cared about it. So I asked him how old he was. He told me. And he said, I said, well, how do you feel about it now? He said, I think I'll be fine. He said, my family's supportive, and I got a lot out of rehab, and I don't want to die. I want to live. But he said, I think it's a shame that you got to come from a family like mine to be able to afford the rehab that I had. He said, why should I live knowing other people are going to die just because they don't have a family like mine that can afford it? I mean, this is a kid. And he says, I'm happy. I know I should just be happy. But he said, I can't get over the fact. I said, let me ask you something. Did anybody ever tell you in college or in high school that if you mixed opioid and alcohol and went to sleep, you could die? Just that one simple thing. He said, no, not once. Not in any class. Why shouldn't we push for that? Just for example. So the good news is everybody from the White House to the smallest farm in America knows this is a very big problem. The good news is there are lots of good people everywhere who are working on it. The bad news is it's still not very well organized. For a lot of people, it's not properly funded. And if you save people's life with naloxone, if they're serious, as all of you know, you got about an hour before you get them to a hospital and start serious detox. Then, if they're serious, you got to put them in rehab. And you got to figure out how to do that if they interacted with, in some way or another, the criminal justice system. This is a multifaceted problem. We have to do this together. And I may be wrong, but I believe that if we don't do what Congressman Cummings said, we'll regret it for the rest of our lives. But what I think is this may be one of those, if we build it, they will come. If we can prove that significant numbers of people, lives have been saved with models, we can get the money we need. We'll be able to overwhelm the resistance. I would far prefer someone take the tax cut that I am being pledged and spend it to save the lives of people like that young man I saw, or the 5 that I knew who didn't survive. So you should feel, in a funny way, privileged to be here, because you are being asked to turn the tide on a great problem that will preserve the lives of people you don't even know, to do things you can't even imagine. Thank you very much. Now, thank you. I want to ask the panel to come up here. First, Tom Geddes, the CEO of Plank Industries, who is also the chairman of the board of a local hospital and very interested in all this. And associated with one of the great American success stories, Under Armour, headquartered in Baltimore. I recommend you go there. It's very humbling. When you walk in, all day, every day, there's a man or a woman or both running on treadmills because they test to see how long the running shoes will last. The last time I was there for 2 hours, and there was a young woman there running on the treadmill at about a 5-minute mile. She was flying, and when I left, she was still flying. And I thought about applying for a job to test the durability of shoes on old people. Maybe it would finally get me to do what I need to do. Randi Weingarten, as I said, is the CEO of the American Federation of Teachers, and I want to say just a couple of words about her. She is, first of all, a former teacher whose students repeatedly won state and national prizes for their expertise in the U.S. Constitution. She's a partner and has been in the Clinton Global Initiative for America, and she and construction unions organized the largest private infrastructure program in the United States. They raised $16 billion. They have committed $14.5 billion. They have spent $12.5 billion. They have created 100,000 jobs and trained 900,000 people to do infrastructure work, and it did not cost you 1 red cent. And I think that's important. Dr. Leanna Wen, the Commissioner of Health for the City of Baltimore, as I said, runs the oldest public health department in the United States of America. And she, I believe, was the first person in America to issue a blanket prescription for naloxone. So that, which she said 30,000 plus people have already claimed. So it's very important that we not overlook things that we could do while we're belly aching about what's not being done. And Congressman Elijah Cummings, as I said, in my opinion, is a guy you ought to just say yes to, because he is thoughtful, smart, tough as nails, and he always shows up for work in a very good way. So, we will begin. Am I supposed to take this? Okay, I'm going to ask you questions, and then if I don't cover something you want to say it anyway. Imagine you're Barbara Mikulski asking for more money for some science and technology project. First of all, what do you think the most important thing we could do now is to get more people to act on this research? I mean, I'm interested in practical things that could actually help millions of people. We've got all this research, we know. And if someone comes in surviving an overdose, the whole plan of action can be undertaken if there was somebody to do it and some way to fund it. But what, in your opinion, each of you, what's the most important thing we could do now to take what we know and make it work in local communities with what we've got? It's okay if you say we need more money, but if you just could take the system we've got, you want to maximize the impact, what's the most important thing we could do?
I was going to say money, so you stole that one from me, President Clinton, but
well, one of Clinton's laws of politics is whenever somebody tells you it's not a money problem, they are always talking about somebody else's problem.
Well, for us in Baltimore, and we're very glad to have the partnership of so many in this room, including the Bloomberg School, we've been able to do a lot with very limited resources by changing policy so that we can get the blanket prescription for Narcan out there. We've gotten 30,000 people trained, but it's not just about people getting trained, it's about people actually delivering the services too. And so I'm happy to report that our latest numbers are that in the last 2 years, everyday residents have saved the lives of nearly 1,500 of their fellow community members just by delivering Narcan to their family members, their friends, their community members. I mean, that's something very tangible that we have been able to do, but as Congressman Cummings mentioned, we're being priced out of the ability to do that. We're actually having to ration naloxone every day. I have about 10,000 units of naloxone to use between now and July of 2018. If I got 10,000 units today, I could give them out by the weekend. That's how much our community is asking for it. So if it's a question of what more we can do, we should scale up existing interventions that we know already work, because we know the science is there in terms of treatment.
So what happens to those people? What happened to those 1,500 people, the ones you brought back?
Many of them are referred to further services. In our hospitals now have an overdose survivors program where peers who often are in recovery themselves speak to those who have overdosed and help to connect them into treatment. Our problem, though, too, is that we don't have nearly enough treatment capacity. And nationwide, only 1 in 10 people who have the disease of addiction can get treatment. So we also need to expand treatment, because saving someone's life now is important. It's an important first step. But they also have to get into treatment to help them longer term.
We do need more resources. There's no doubt about it. And I'm convinced that people, Mr. President, do things for 2 reasons. or a combination of both, one of two reasons. Either to avoid pain or gain pleasure. Avoid pain or gain pleasure. And I think we have to convince our policymakers that they should not be trying to reduce Medicaid. They should not, where a lot of people who need this treatment would be able to get it. Well, at the same time, we see members of Congress crying at the funerals and on the 6 o'clock news. But when it comes time for making sure that the programs are there to help their very constituents, the ones that live right up the street from them, suddenly they get amnesia. That's very unfortunate. Another, and last night I called my a fellow who's been off of drugs for 30 years. And he's like, I said, Ricky, what can we do? Because just the very question you just asked. I said, what can you do? And he said something to me that I didn't think about. He said, Elijah, in Baltimore, we've got a whole army of people who used to use drugs. Some kind of way, we need to find a way to get, and those are the people that are most adamant, if you've noticed, of trying to help other people get off of drugs. In some kind of way, we need to use them because they've already been through the pain. So through their pain came their passion to do their purpose. Come on now. Pain, passion, purpose. And so Narcotics Anonymous, we need to also encourage people to be even more a part of that. Because these are people that are out there and they've already been through it. And so, just some thoughts off the top of my head.
Mr. President, to answer your question of what happens to the people who are revived under Dr. Nguyen's plan, we had a patient at the hospital where I'm the board chair who was revived. And what happened by law enforcement, what happened was next he was revived by the fire department. The third time he was revived by a fellow user who went behind a dumpster to use drugs, found him unresponsive, and had Narcan with him and revived him. Where is he now? He's sober, and he's working, and he's alive. And that's the work Dr. Nguyen's doing here in Baltimore.
So to that point as well, I just, look, education is absolutely imperative, but it has to be coupled with a quick intervention like Narcan. And what we saw, for example, is our nurses in Cleveland. We're now the second largest nurse union in the United States. And the nurses, a school nurse in Cleveland, demanded that the Cleveland public schools actually have a supply of Narcan in every single school. When they didn't get it, they got a grant to do it. And now they're getting it because this nurse actually revived a parent of a child. And I tell that story because the stories are important to destigmatize and to educate. But I think I think your point, Mr. President, about they will build if we have enough pressure on the system, but that pressure comes with education. And then, and so, for example, Dr. Nguyen was at our conference this summer with, actually, I call her Dr. Mona from Flint, talking about the issues in terms of water and the issues in terms of opioid addiction and the epidemic. But I also couple it with a stick, which is there are a lot of worker pension funds that are invested in big pharma. And so we are actually starting to do, frankly, what the New Yorker magazine did this week as well, in terms of creating some public pressure to reduce the prices and use the public pension funds as a way of trying to figure out how to reduce the prices of Narcan and other absolutely effective intervention drugs.
Are there any public school systems in the country you know of that actually have some policy of educating kids about the dangers of this and telling them basic things like what happens when you mix opioids and alcohol of any kind? I mean, it looks to me like What have we got to lose by having the appropriate experts approve a paragraph or two that can be read to every school kid in America at the opening of every school year? What have we got to lose? A lot of people, I'm convinced, are still dying in ignorance. I mean, you know, I think our preconceived notion here is often right. You got people who use these opioids over and over and over again and then finally die. They overdose as addicts. Or they trade down to heroin or fentanyl or something and they finally die. But there are lots of people who are being killed by the combination. That's just one example, but is there any school district or any state that says, as a matter of policy, we have run this by all the professionals, we want every kid in our coverage to hear this particular message?
We actually just got legislation passed in Maryland so that we are, in Baltimore City, for example, we're working with our schools to implement standardized curriculum on this topic. It's complicated. If I go to one of our schools and ask if the students think that using heroin is good or bad, they'll all say, unless they're trying to be snarky, they'll all say that heroin is bad. But if I ask them about prescription drugs, they might give a different answer because they see their parents or their caregivers every time they have knee pain, they're taking Percocet, or they have back pain, they get Vicodin. And there is a culture that we have, as you have spoken about, Mr. President, about this pill for every pain culture, that pill is being used to treat physical pain as well as potentially emotional pain and deeper other types of pain as well. So I think that culture has to change from the medical profession. It also has to change from each and every one of us with regard to prescription opioids.
But shouldn't these kids know that if you can abuse these things and they could kill you? Are there parents?
I don't know about school systems, but let me tell you one thing. When I was growing up, the first overdose I ever heard of, I was 7 years old. That was 60 years ago. I was 7 years old. I didn't even know what drugs were. I didn't even know what overdose was. All I know is Bebe, one of our neighborhood guys, had died from an overdose. And I think education is important because for me, my entire life, I've never touched an illegal drug, none of that. You know why? I was scared. I was scared that my destiny would be ruined. I really was, and still am. I don't play. This life is precious. But I also understand the argument, Mr. President, that is made when people say that, well, we want to make sure that people get the relief they need under certain medical circumstances. Because when I was here at Hopkins, I'm going to tell you, I didn't know you could be in that kind of pain. I really did not. Every morning, I'd get up and I was in so much pain, you almost want to die. And so I can see where people can get to that point. But there's something else we can do, and that's one of the things that we're looking at in our committee, is why is it that the insurance companies favor paying for the cheaper, addictive type drugs, come on now, as opposed to those drugs that are non-addictive or least addictive, that are more expensive. And we are doing a lot of research on this right now in my committee to address that issue. I mean, there's a lot to this. But again, I am convinced, yeah, if you tell somebody, some people you're going to die or you're going to be harmed, it seems to me that some of them would say, no, I'm not going to do this.
It's, look, when I was a kid in 7th and 8th grade, we actually had health classes. And it was a different period of time. And, you know, there were a lot of jokes about the Nancy Reagan just say no on, you know, drugs that ultimately people corrected and understood, stop stigmatizing at that moment in time. But there is some place for having a real focus in schools on well-being. And I, frankly, have flipped my own advocacy on schooling to start first and foremost with focus on children's well-being and then on powerful learning. Because I think we have to actually meet kids where they are. And I think we should think about, in light of having the new federal policy that de-emphasizes tests, to really think about how we do some of these things in schooling. Childhood obesity was an issue as well, but it is about how we try to focus on well-being and have some kind of health-related work for kids in elementary school, in junior high school, and high school. It will be different pedagogically, obviously, and developmentally for each of those years, but it's really important. And I think it's more important, unfortunately, than just at the beginning of the year, going through the list of all the things we want to tell kids, because that paragraph could be lost while Elijah and I are talking to each other and not listening to that paragraph. And so that's why I think we have to try to figure out pedagogically how to do it in a way that really goes to children's well-being.
Well, I just skipped the middleman, and I brought my 5th grade daughter today, so I figured this would be the best possible free class for her. So. But kidding aside, Lauren Geddes is here, but kidding aside, it's not too young for her to hear about it. And Mr. President, to your comment about where do they hear it, my wife had a full hip replacement last Wednesday at the grand old age of 41, and she took the time to educate our children as she was taking herself very rapidly off of the narcotic medications that she needed. And she explained to them, she talked to them about the fact that she needed them, and she made sure that they understood that getting off those drugs was a priority. And that probably is not happening in a lot of households. She's an exceptional mother, and our neighbor is Dr. Lena Wen, so we knew we were under some supervision too. But while she was in the hospital, and I'm doing disservice to an organization I'm involved with here, I noticed that on the whiteboard for her nursing staff, the pain protocol, where it had last dose, pain level out of 10, the tagline was, "Your comfort is our priority." Your comfort is our priority. And this will be something I'll be bringing up at the next board meeting, is to say, no, your recovery, your health, comfort is not necessarily the priority when you've had a full hip replacement. It's going to be uncomfortable. As the Congressman said, it can be very uncomfortable. And her doctor was excellent in saying, you should be managing your pain to a 7. You had your hip replaced. You shouldn't be managing your pain to a 0. But that's not the message we're getting, and it's not the message that kids are hearing, unless they're lucky enough to get to come to a session like this.
Let me ask you this. How much of a problem do you believe is a part of this continued overprescription is? Either a prescription of an opioid when a non-opioid painkiller would be effective in certain circumstances, or prescriptions in amounts too great to be safe to leave in one place. How much of a problem is that still? And if it's a problem, what else can we do about it? And is there something that private or public entities that insure lots of people can do to pressure the system to clean it up?
My confession as a physician is that I have overprescribed opioids to many patients and not realized it. In medical school, in my medical training, I didn't learn about the addictive potential of opioids. I just learned, as Mr. Geddes was saying, that it's important to take away patients' pain. And we doctors want to do the right thing. We want to help our patients. And so if they say, I need opioids, or if they say, I'm in pain, we give it to them. That tide is turning. We are beginning to change our mindset. I'm hearing our medical schools in the city and also our hospitals now changing their practices. We've convened all of our doctors, our emergency department doctors, our primary care doctors and dentists to teach about the addictive potential and to talk about why we need to decrease the trend of overprescribing. But I think that there's another issue too. This is the supply side. There's also the demand side too, because as long as we have people who have the disease of addiction, they will continue to seek out prescription drugs or heroin or fentanyl unless we can get them into treatment. And so it's our recognition that addiction is a disease, that treatment exists, recovery is possible, and that we have to get treatment to people whenever it is that they're ready, while also working on reducing the supply of drugs by reducing overprescribing.
So, you know, I think the answer is yes when you have a big enough, you know, when you have a big enough health care insurance pool. Like, for example, the city of New York, when I was the union president at the UFT, we had the entire city of New York's families, and we were a very, very big foot in the kind of negotiation with drug companies, and when you could negotiate with drug companies, and the negotiation with PBMs. And I think that there is a lot to be said towards that. I think the dilemma is, as the doctor just said, look at what's happening with fentanyl. And so if we don't actually deal with the issues of treatment and the issues of education, there's always something somewhere that is going to be there for either pain or joy. And that, I think, as Congressman Cummings said, we have to change enough of policy and enough of education and destigmatize, as you said, Mr. President, to try to deal with the root cause.
You know, Ms. Weingarten just mentioned a word that I think we all need to kind of center on, and that's stigma. You know, Mr. President, when people find out that they see somebody on drugs in their midst, a lot of times they look at it as a moral failing. In other words, this person just can't make decisions right, or they're weak, or they're looking for the easy way out. And a lot of times people, by the way, are therefore afraid to even come forward. They're not like the situation that you mentioned, Geddes, where you're able to get somebody back on their feet and moving. The employer will say, well, wait a minute, you know, I've got 10 people who need jobs, and all with no drug problem, and I got this one person who's got a drug problem, maybe a good employee, but why do I want to risk that? That's a tough one. And getting past that, but in talking to the people the former drug addicts that I've talked to, they tell me that basically a person does have to hit a rock bottom. They really, but they've got to be able to get that treatment and get it quickly. And I think that's what we've got to work more and more towards, trying to get that treatment and get it quickly. But there's another thing that we've got to make sure we do, and that is make sure that the treatment that is given is effective and efficient. Because you got a lot of people putting up little storefronts. Now, I'm telling you, I don't want to mention any names, but there's certain parts of the city you can ride in, and you'll see big signs, you know, come get your methadone. And so people are, I think, going there getting a coping drug, and I'm not knocking methadone, but there's nothing else going with that. And the experts up here, Dr. Wynn can tell us even better, that usually if a person has a drug problem, there's something, a mental illness situation there connected some way. So you can't just deal with just the drug problem. You got to deal with the other things. Am I right, Dr. Wynn?
Absolutely. We need to follow the science. And the science is that treatment for opioids exists, that there are millions of people in long-term recovery, and it's a combination of medications, including methadone, buprenorphine, or naltrexone, with counseling, and also with other services, because housing, for example, is healthcare too.
Let's talk about that, though. First of all, I'm glad that the last 2 or 3 comments I think have been very helpful. The thing I was most impressed about that woman I met in that little town in Ohio, is that she said, I don't know what I'm doing. I want you to put me out of business. I'm not getting paid for this. She said, I got no business doing this, but nobody else is here. So I thought, I trusted her because she said, please put me out of business. I'll be glad to be a counselor in somebody else's efforts. Okay, so we say, what is the answer out there? Let me ask 2 specific questions. How adequate is the coverage today under Medicaid? How adequate, how much do private insurance companies that theoretically cover this require waiting periods, and what are the possible downsides to that? And if you were starting from scratch, if you could wave a wand, would you locate at least initial assessment and treatment in local public health units, properly funded and staffed and accessible to law enforcement, to emergency personnel, to others? Or would you, or is that totally impractical and should people just be going to doctor's offices or specific programs? I mean, my feeling, is the capacity there to treat all these people if the money was there? And if it's not, where should it be built out? So, number 1, how adequate is the coverage? Number 2, are waiting periods still a problem with private insurance? And number 3, how would you deliver it even if everybody was covered tomorrow? We'll just go.
I'll answer the last part first, because one of the major issues that we see here is that even if we have enough treatment, which we don't, but even if we did have enough treatment slots, and even if we had enough payment, which we don't, but even if we did, a major problem is that we cannot connect people to those treatments. So there may be somebody who is ready for treatment now because they're not reaching the individuals in time, or they're not getting services where they are. What we need, for example, so in our health department, I oversee our needle exchange programs. We have needle exchange at over 20 sites across our city. Somebody may come to our needle exchange van and say, I'm ready for treatment right now. We need for more people who are able to connect them into treatment and say, here are 5 different options for you. You don't have health insurance now, but I can help you get there. I can physically take you to this treatment center. If you're ready right now, I will help you do that. It's those types of connections that we don't currently reimburse for that we need to figure it out. We started a program in Baltimore City called LEAD, Law Enforcement Assisted Diversion, where individuals who are caught with small amounts of drugs are now going to be offered treatment rather than incarceration. It's a pilot program, and it's already been very successful, but it's very time-intensive, very resource-intensive, and currently funded by grants, not reimbursed through medical insurance. So it's those types of peers, speaking of peers who've been there themselves, walked the shoes of the people that we serve, that we need to figure out how to pay for and connect into treatment.
If you had the money to pay for the connection stuff, everything you just said, where would you lodge it? I mean, the ultimate, but look, if you got your standard, I'm addicted to painkillers, this is the 3rd time I've shown up, naloxone saved my life, you got me in the hospital, so you need to put me into detox. I go through detox, detox is over, now I got to go into real treatment. Where would you put that? Well, who's going to provide that?
I put it everywhere I could put it. But let me tell you something, Mr. President. The problem is nobody wants certain things in their neighborhoods. Come on now, don't act like you all don't know what I'm talking about. They don't want it in their neighborhoods. So as elected officials, I mean, we am I right, Senator Kulsi? I mean, it's really a hell of a battle. I think in those rural, I remember seeing on CNN where they were talking about this West Virginia town that basically they were getting all these millions of opioids, and the population was 300 people. So people were just flocking there, and of course a lot of the 300 had problems too. So I would want those facilities all over the place if I had the money. And then I would try to, again, get people who've been through it to invite other people to participate. I mean, Dr. Wynn and Senator McCarthy, big advocates of Healthy Start. Healthy Start is based on women who've had babies. Am I right? They've been through it, so therefore they're able to teach others and encourage them. So, you know, if I've got a drug problem and I come to you and you say, man, just like the fellow I talked to last night, my friend Ricky Faison, who's a former drug addict, 30 years off, you know, you go to Ricky, you say, Ricky, man, I got a problem. He said, man, well, look, I'm a barber, I'm doing well, I'm making money, you know, and I'm doing for my neighborhood, and I've been where you are. I've been where you are. Let me take your hand and take you to this place. That will make a difference. I'm telling you, it'll make a difference.
So it's kind of dealing with this. So let me start this way. When people have cancer, they make the connections. Because there's a sense that cancer could affect all, it's not stigmatized, people try to get well. So that's why the stigma becomes really important to address. That this is a national crisis. And born out of a lot of, and you and I have talked about this before, McDowell County, West Virginia, where we work, is one of the highest opioid epidemic users. And we saw that 5 years ago, and we said, what's going on in Ohio, in West Virginia? The anxiety of loss of jobs, loss of hope. And so we have to flip the switch on the stigma and then try to figure out how to do this, I think, through employers, through medicine, through doctors, and do it in a way that gets more and more treatment centers built and more information out there in a way which is positive and proactive.
Well, as the Congressman said, the cost of doing nothing is not nothing. We can't afford not to find the money. This, from an economic perspective, this is what I call an unnatural disaster. So, Mr. President, you mentioned the figure of $78 billion of annual economic impact. Hurricane Sandy, which was about 5 years ago, I think was $65 billion. So we're talking about a major hurricane hitting the northeast of the United States level of economic impact that we're suffering from this crisis. Not to mention the loss of life, which is like a Hurricane Katrina every 3 to 4 weeks. And so we cannot afford not to make this a national priority. We're worried about travel bans and walls. This epidemic is killing more people than international terrorism has killed since 2 years before I was born in about 3 weeks. I don't think we have the awareness that the people in this room have. I don't think there's national awareness. I don't think employers have that awareness. And employers need, in terms of making those connections, where do we spend our time? We spend our time at work. That's where we spend most of our time. It's a sad reality as Americans. It's what we do. And if our HR departments and our managers and our employers are not recognizing these issues and helping to make those connections and treating it as if they would treat an employee with cancer.
Well, what's your sense about how large employers are handling this? Is there any kind of general consensus? Do they really believe do they make their employees feel like they won't be fired and they will be helped if they show up and say, I need help? Or do they, in effect, confirm the what you might call the stigma bias by making them think they're toast if they have to fess up?
I think my sense is that there are, on this issue, as with the broader issue of hiring returning citizens, I think there are a handful of companies, including some very large companies, that are demonstrating real leadership. And we saw that under the Obama administration with the Fair Chance Business Pledge. I was in a room with 12 or 15 very large national employers, Coke, Pepsi, FedEx, a whole bunch of big employers who are very upfront on these issues. But a lot of people don't work for those companies or work for large employers. And a lot of people who are struggling with these issues work for very small employers or don't work at all. And I think that's where that's where these public health interventions are going to have to take place. But I think the conversation is beginning. But given the numbers I was talking about, given the economic impact I was talking about, given the impact on lives, the conversation in the private sector is way behind where it needs to be, in my view.
Do you think there's a difference, and maybe Elijah could talk to this too, but do you think there's a difference in the degree to which stigma remains a problem in small town and rural areas as opposed to urban areas, or do you think it's pretty well uniform?
Oh, I think stigma is everywhere. I think it's everywhere. You know, people have a lot of pride, and first of all, to even acknowledge that you have a problem, people don't want to admit that. They just don't, and then they go throughout their lives deny, but yet and still they're as the people that I've talked to tell me, by the time a person is going into the medicine cabinet to use mama's pills, they already got a problem. They already have a problem. It's not, you know, people just assume it's almost like your 16-year-old just drifted off into your medicine cabinet and saw something and thought they were M&Ms. No, they knew exactly what they were doing. So it's already, so we've got to concentrate on education and trying to make people realize how significant problems can arise. When I was chairman of the committee on drugs, of the oversight committee many years ago, we had some students, Mr. President, come in from Baltimore. We had about maybe 50 of them from Baltimore to test the commercials. Just to see how they felt about the commercials. You know the one commercial that had the most impact, and all of you will remember, is when they said, this is, when you use drugs, this is how your brain looks, and it was an egg frying. I mean, by far, it was the #1 commercial. And a lot of it has to, we've got to make people realize that this is not the way. And I know we're going to be closing up very soon, but I got to say this, Mr. President. When I look at this audience, and it is just the idea that we're sitting here, and I want to thank you, by the way, for doing this, and Hopkins. But you all are the ones who must help drive the policy. Because you are the experts. You know, you got firsthand knowledge. You're the ones. You've been trained for this. And so, you know, we look forward to work. When I said at the podium that we're all an army, we are an army. But you are the super experts on this. And you know the impact. And you know that what you do or don't do can affect generations yet unborn.
Thank you. That was great. Let me say why I asked the question I just asked about the stigma. Maybe it's just my experience as being a slightly guilt-ridden member of a family that's had addiction in it. But I believe the stigma extends to family members and coworkers. And I believe sometimes they are the most important. Depending on how bad an addiction is, a heck of a lot more people know it than the person believes know it, or they suspect it. And that's why the culture in a community, in a workplace, in a religious setting, all these things matter, because I believe that the stigma sometimes hangs around the neck of family members and coworkers and others, maybe even more than the person with the addiction who wants to scream for help but is scared. They see all the rest of us walking around like we're, you know, wanting to pretend it ain't so. I'm saying this is a confession, not a criticism. I'm telling you, and I think, so I believe when this whole stigma thing is discussed, yeah, you want the person with the addiction to come out, but I think really the whole, look, all these little towns, I was born in one of these little places that's supposed to be the epicenter of this epidemic. Everybody knows everything. just about. Somebody knows in these little places. And maybe somebody knows in the microscope, you know, Manhattan, people think it's such a big place, it's really 1,000 little neighborhoods. But, so I think that it's, only reason I mention this is, my view is, this stigma message, we got to be careful because it sounds like it only applies to the person with the problem. But if you know the chief of police in your hometown does not want to put your brother in jail, then, and you know that you don't have a clue how to get your brother in a treatment program or your sister or whatever, you ought to go to the chief of police. This is the message, in my opinion at least, having been a family member and onlooker of all this on and off for, I don't know, 40 years. We talk about stigma as if we're all being broad-minded by reaching out and trying to make the addict feel good enough about himself or herself to come out of the closet. This is a bigger problem than the person who needs the medicine or the treatment or the psychological counseling. And I think that it's one of the reasons I wanted us to do this today, just so we could, you know, there are a lot of people like you who are out there on the front line of this that could lose a little help from your friends here if we all just, you know, get over it. This is a big deal. We would like to stop every single solitary person we can from dying. And along the way, we'd like to give them their lives back, which they have to claim. And anyway, I'll get off my high horse here, but I think we don't need to be patronizing when we talk about stigma. It's as though it's a delicate thing. Well, the stigma is something that a lot more people participate in than the employer or somebody in some oversight position and the addict. We're about to wrap up, I think. Anybody else want to talk? You got anything you hadn't said? Say.
I just to your point, I think it's also, we have a lot of different cross currents. So, for example, we know that after school or community health care plans would actually be helpful, and then when they get cut, it makes it harder. We know that in terms of employers, we're all looking, I'll put my employer hat on, we're all looking for how we can squeeze that last dollar out of the health care plans. And so if we're not going to actually pay for an EAP program, if we're not going to pay for those kinds of things, that's a cross current that hurts this. And so the alignment, the Medicaid, that you need a waiver to get to go to a treatment facility that's more than 16 beds, why have a waiver? Why not just change that law? So I think that part of it is also, there's a whole bunch of things that we need to do to be consistent, as opposed to having this kind of cross current that basically says, oh yeah, this is important, but I'm not acting like this is important.
I just wanted to say thank you to you, sir, for shining a light on this. The last time you and I were together was at a summit for America's Promise. And today we're talking about what really is America's crisis, and that I don't think people understand is America's crisis. So to have somebody of your stature in partnership with Johns Hopkins, not only a former president, but also somebody from a town called Hope. So thank you.
I want to close with somebody who actually knows what she's talking about. But keep in mind, Baltimore is not only the oldest public health unit in the country, it's on this score one of the finest. And you said, even if you've got a treatment center somewhere, you don't necessarily have the transaction costs aren't covered. And this, I think, is important. I wanted to mention this. When I was the governor of Arkansas in my former life, and we were the second poorest state in the country, we early on had one of the highest vaccination rates for basic vaccinations for kids 2 and under of any state in the country. And I would like to say it was because of my sterling leadership. but it wasn't. It's because we were so poor in the Great Depression, and a lot of southern states were, that the government helped us build out the public health network. And then, centuries later, when people started suing people over vaccines and docs didn't want to do it, we literally provided 85% of the vaccinations for little kids in my state through public health networks. In other words, we were the connection. And so that's why I ask you about the public health infrastructure. Somehow we need to come out of this, all of us, with a clear idea of what kind of infrastructure we need that's not there. Not just what Elijah said, which I totally agree with. You know, I'm all there on the, you know, Medicaid should cover and we need more money for all this stuff. But the public health infrastructure is peanuts compared to the $78.5 billion we're blowing, never mind the value of all these people's lives we're losing. So talk a little about that. Do you think for a relatively modest amount of money you could do a heck of a lot of good if you had that?
Absolutely. President Clinton, you remind us of the saying that public health saved your life today, you just don't know it. And,
oh, I do.
we just don't know it. And,
no, I agree with you.
And I'm fortunate in the city to work with Senator Mikulski and Congressman Cummings and Congressman Sarbanes and so many who've helped us with doing things that are very difficult, with starting needle exchange, for example, more than 2 decades ago here in the city, where a lot of people said things like, well, isn't that just going to make people use more drugs? But what we've seen is that the percentage of people with HIV from IV drug use has decreased from 63% in 1994. It's now 7%, from 63% to 7%. That's what public health can do. And so I would say, as a call to action for all of us in building the public health infrastructure, but in general in what we can do, because sometimes the opioid epidemic seems so big. But I think there are 3 things that we can do today. First is learn to use Narcan, because we can all save someone's life, and you've been such a great champion of that, Mr. President. The second is to change our language, change the way that we speak about the issue. And Director Michael Botticelli, who you'll hear from, taught me a lot about how we can reframe our own language around speaking about the disease of addiction, for example, rather than talking about addicts, or just simple things that we can do that make a big difference. And I'd say the third thing that we can all do is think about what is in our wheelhouse. If we're a hospital, instead of leaving it to another hospital to take the lead, what is it that we can do as a hospital or as an employer? What is it that we can do as an employer or a union or a policymaker? So I thank you for supporting us in building our public health infrastructure and for raising awareness of the issue today, Mr. President.
Thank you. Let's give him a big hand. And, thank you. They were wonderful. Now, I just want to say one thing while we get off. The next panel is about the report that the Bloomberg School and our Community Health Matters Initiative did. The report had some very specific recommendations. The purpose of that, in my ongoing obsession with this issue, which is that too many smart people in America spend too much time meeting and nothing happens, is that we all pick something out of this that we can and will do. That's why I began by mentioning the 3 things we're going to do coming out of this. So I urge you, this next panel is really good, really impressive, really active. So figure out what you can do and commit to do it as a result of what they say about these recommendations and their experiences. Thank you, and bless you all. Thank you.
Hello, everybody. We're about to get started with our second panel. I'm trying to be very respectful and not upstage the president. That would not be a good thing. Good morning. My name is Michael Botticelli. I'm here at the Johns Hopkins School of Public Health. The dean gave me a very fancy title, which I'm not going to say. But I also had the privilege of being the director of the White House Office of National Drug Control Policy under President Obama. And really excited to be here today. Actually, our work in Washington, we worked with many of these people on the panel, but very closely with the Clinton Foundation in terms of our response to the opioid epidemic. And as the president indicated, I think we really have and understand this as a multifaceted problem that manifests itself on the national, state, and local level. And we need a multifaceted response. And we have a tremendous group of panelists here today who, in their own way, have been continuing to focus on this issue at various levels. And I think they're going to talk a little bit about the work that they're doing today. So let me introduce them. So to my left and your right is Erica Paulette, who is the Senior Community Minister and Shaping Sanctuary Project Director at Judson Memorial Church in New York City. We also have Chief Synan from Newtown, Ohio, who I've had the privilege of working with for many years now. Next to him is Dr. Carol Forster, Physician Director for Pharmacy and Therapeutic Safety, Mid-Atlantic Permanente Medical Group. And finally, Jim Hood, who is the CEO for Facing Addiction, which I think is an organization that many of you know. So let me start off. I'm going to ask Jim to start here. So Jim, like many parents who've been impacted by this, we heard very personal stories today. So you're one of many parents who's been personally impacted by this, and kind of out of your grief, you changed that into advocacy and action by leadership of a national group called Facing Addiction. So why don't you tell us a little bit about the group, but also to this theme of evidence to impact, kind of where you see where we are now in terms of where we've made progress, but really where do we need to continue to ramp up our efforts here to really implement what the president said, and that we know what works here. So give us your assessment in terms of where we are now and the kinds of efforts that we need to continue to move forward.
Sure, thanks, Michael. And thanks to the Clinton Foundation and the Bloomberg School, and some very nice words from President Clinton. We're Facing Addiction is very excited to be working with the Clinton Foundation and trying to make greater progress at slaying this dragon. Yes, I did. I lost my oldest boy, Austin, to this horrific thing 5 years ago last Thursday. And so, you know, we soldier on because this work is so important. And I want to, I think stories are so important, as you heard from the first panel, but I just want to paint a very quick picture and then also kind of paint a landscape. I understand the focus here today is the opioid crisis, as it should be. It's horrific, but it's also the tip of a spear within a larger problem, which is all addiction to alcohol and other drugs. And this is not to divert. We must focus on the opioid thing, but we ultimately have to tackle this whole problem that is just getting worse, and it's getting younger. And you know, there's a staggering figure about how many people die from opioids, but someone dies every 4 minutes. That figure, by the way, is probably understated, but that's for another day. Somebody dies every 4 minutes from addiction in this country, addiction to alcohol and other drugs. That's 350-ish people a day, and we sometimes talk, and it's jarring, but that is a huge jet. It's a huge airplane, and it's also often young adults. You think of young adults, bright-eyed college kids, maybe they're going to Europe to, you know, do their international studies. That is a freaking jet falling from the sky every day, and somehow, and we're trying to work on it. This country, I think at this point, everybody is concerned about the addiction crisis. I don't know if they care enough. I don't know if they're brokenhearted enough, and maybe we've got to get from statistics to absolute grief, because you put that figure in perspective, and you know, none of these are value judgments, but the first panel mentioned, you know, the devastation of hurricanes. I mean, what that animal did in Las Vegas is unspeakable. Yet we have 6 Las Vegases in terms of deaths from addiction every day in this country. And somehow we don't rise to the occasion. And we simply have to rise to the occasion. Or, as President Clinton said in an earlier speech, this thing is going to eat us alive. So, our work, Michael, to try to keep it conceptual is, President Clinton also mentioned that in the aggregate, the country's gotten so little done, and also in such a disconnected way. We hope to get a lot more done, and part of that is to connect all these different parts. And I could paint a picture for you, I'll be very brief, but I could paint a picture for you that is both frustrating but hopeful, because if you think of the journey of a young person in this country, from prevention to early intervention to their interaction with regular health care, there are clear identified problems. They're in this report, they're in the Surgeon General's report. There are problems with prevention. It's the wrong programs. We don't go to where the kids are. There are problems with early intervention. Our pediatricians are insufficiently trained. We talked about doctors who overprescribe because they only get a few hours of training in med school. Some treatment works, a lot of it doesn't. It's not scalable, it's not affordable, it's not integrated with the healthcare system. There's still too much of a criminal justice response in the country that's got to be shifted. Long-term aftercare is not what it should be. But we know what to do in every one of those boxes. We just don't do it. And we just simply have to stop talking about it and doing it. So, in the largest sense, Facing Addiction is a national group, think of it as the American Cancer Society, to try to integrate the private sector's response to this crisis.
Thank you. We could follow up on some of those. So, Erica, let me ask you a question. So, our faith, should I call you Reverend, or is it okay to call you? Okay, thank you. So, our faith institutions have long been engineers of social justice change in the United States, and I think particularly for highly stigmatized people and highly stigmatized diseases. And I can't. When you think about the faith community response to the HIV epidemic, and a lot of us have talked about the parallels of that. But so talk about what you're doing, and I think I want to go back to what Dr. Wen said in terms of how we think about harm reduction as an approach to this. So we know many people are not ready to seek treatment, but we know we have to keep them alive and keep them healthy. So why don't you talk about your work, kind of the harm reduction approaches that you're taking, but also kind of the call to action to other faith communities in this epidemic.
Great, thank you so much. Yes, it's wonderful to be invited into this conversation. Communities of faith have played a really significant role in, we have in essence created a community of lepers by, stigmatizing and shaming folks. And we have, what the church says is as important as what the church doesn't say. I gave a sermon earlier this year on the gospel of harm reduction, and within hours, I was receiving hundreds of emails, phone calls, encounters with folks in the church, in the community, in the halls of Harm Reduction Coalition, where I also work. People said they had never heard the drugs issue talked about in a sacred space. They had never heard the drugs issue talked about and imagined with a compassionate response. They had never heard their story reflected in those rooms. They had never heard their child, their loved one, and their self called beloved. That's really significant. The church is really charged with making a space and a place. And in order to do that, not only do we need to extend radical welcome, but we need to make sure that we are, examining and tearing down those barriers that delimit folks from accessing help. I, by virtue of a double belonging, work both at Judson Memorial Church as well as at Harm Reduction Coalition. And by virtue of that double belonging, have had the opportunity to listen into both spaces and to really, identify a deep need that communities of faith
especially in communities that are particularly vulnerable to drug-related harm, they are often the points of access. They are often the ones with the most well-developed social networks. And so it's really critical. And so what we have taken on is the Shaping Sanctuary Project, which we are working on mobilizing faith leaders across the country to be able to speak prophetically to the humanity of people who use drugs, to be able to be a resource in their communities and for their congregations, as well as being able to advocate for compassionate drug policy.
I want to follow up on that because this is a really good example where kind of the evidence of what we know to be effective is a far cry from what's been implemented. And we've known, for example, that access to sterile syringes and even naloxone are proven intervention strategies. What do you see as the significant disconnect between kind of the evidence of what we know and why we, in some respects and in some places in the country, are still debating this?
There's a multifold answer in there. I think quite honestly, there's an immense amount of wisdom, expertise, experience. People are doing this work. People who use drugs and their loved ones have been saving each other for a really long time now. And it really is, it's connection, collaboration, I think is really the key to addressing this issue. And in doing so, it's going to be connection with folks with lived experience of overdose, drug use, with families, with the first responders, folks who are on the site at these overdose encounters, and that we really need to be, and this includes harm reduction programs, which are constituted largely of folks from these same communities. And it's the community, people who are the experts are the ones that we really need to be following. We need to be taking our charge from them.
Michael, can I follow up on that?
Sure.
You guys said something very important. Here's one of the things I think that would shift. So in Hamilton County, we have all the right people, all the right organizations. One of the big things we need is funding, but one of the things I think would shift this dramatically is stop treating addiction as a crime. Take it out of the criminal justice system. Take it out of the criminal justice system, put it into the mental medical health system it should be. We can't get past any of this until we get past the part where everyone thinks that every user is a criminal. They're not. Allow us in law enforcement to do the job of cutting down the supply. Allow us to be the link to all these other organizations. And I think we'd see a dramatic shift, but until the public stops seeing this as a crime, we're going to have difficulty. So that's the first thing we need to be doing.
So, Chief, let me follow up on that because I think many of us have remarked on the tremendous shift in law enforcement, right? So you're not the first chief where we've heard we can't arrest and incarcerate our way out of the problem, that we have to partner with the public health and community folks. So how has that changed your work at the local level? Who are your new best friends at the local level in terms of the work
I didn't know what a health commissioner was. Sorry, Dr. Wen, wherever you are. I had no clue. But one of my best friends is the city and Cincinnati and also the Hamilton County health commissioners. I work with them extensively along with treatment. We actually worked with Cincinnati and Hamilton County health commissioners to push out Narcan to every single police officer in Hamilton County and Cincinnati. Over 1,100 doses. There's been 7,500 uses of Narcan in our area in a year and a half. And we had a great conversation because when you're dealing with cops, like I told the health commissioner, he's like, hey, should we do like needles? I'm like, don't give a needle to a cop. Can we do something simpler? He's like, well, we got this spray. We can do spray. So, so we pushed that out there. So he's one of my closest cohorts along with treatment. And I think law enforcement, to say the bad part of this, we stand over the bodies. We inform the families. So for us, it's real. So we know that we can't solve this ourselves. It's beyond us. So we need the people that can get people into not just treatment, but care. Long-term care so they can reintegrate back into society, so they can get jobs and have their life back. And we talked about investment. We're spending so much money on the front end. Why don't we put it on the back end and get people back in? We get our investment back.
But let me talk about, so what are you seeing at the local level in terms of the major deficits that you feel? So you talked about how do we get people into treatment, get them the long-term care they need, give them housing, employment. What's the biggest need that your community faces?
I'm just going to say it straight out. It is funding. There is no two ways about this. We call this an emergency, but we don't treat it like an emergency. We have 50 to 70 people overdosing every week in our area on average. 4 to 5 people dying every week. And yet the money's not there. We have all the right people, all the right organizations. It's not like treatment doesn't want to help, that there's not harm reduction. It's not like the community doesn't want to help. We don't have the resources to do it. We don't have the doctors, the peer mentors that can go into the community. We don't have the links. We don't have that. And it needs to come down to money, and we have an opportunity to have that. And I hope that we don't let that go. This is the time and the moment that we can shift addiction. And and the congressman was 100% right, and I've been saying this for a couple of years now, it takes you. All of you need to get a hold of your policymakers and tell them to give us the money, that this is an emergency so we can fix this. It is not a waste of money. It is an investment of money.
Great. Thanks, Chief. So Carol, I want to shift a little bit, because we were talking, Dr. Wen, I think, in a very confessional moment, talked about the fact that as a physician got little to no training on opioid prescribing, on substance use issues. And we know, even with well-intended efforts, that was a significant driver. And part of our efforts now is this balanced approach, which I think I really want you to talk about, is we clearly want to make sure that we're diminishing unsafe prescribing practices, but not have the pendulum swing so far in the other direction that we're under-treating pain again. So why don't you talk a little bit about your efforts and your balanced approach here to reduce opioid prescribing, but still ensuring that people get adequate access to pain management strategies?
All right, thank you, Michael. First, I just want to say thank you for the invitation to be here among all these distinguished colleagues, and to President Clinton and the Clinton Foundation and the Bloomberg School. Kaiser Permanente is a national health plan, and although we're not the entire country, we have a little tiny section of the country that we try to help. And for those 12 million patients that are part of our health plan, we really do want to make sure they are receiving the safest and the best care that we can possibly afford. And what my role is as a director of pharmacy and therapeutics, is I try to use my expertise and my background in educating our physicians as well as our patients regarding safe opioid prescribing, but also, more importantly, the appropriate management of chronic pain. And that's really where our focus has been. About 6 or 7 years ago, all across our health plan, which is present in 8 states and the District of Columbia, we have implemented guidelines around chronic pain management, as well as safe opioid prescribing. So yes, I've heard the comment that, well, you're taking away opioids from people. They're going to be in pain. No, we're actually augmenting our chronic pain treatments, and we're augmenting the ability to prescribe non-narcotic or non-opioid treatments, and in fact, first-line non-medication treatments. Really, it's not always medicine that will help you with your pain syndrome. We make use of significant alternative medicine treatments. Exercise, weight reduction, simple things can actually help people with back pain, for example. We have pain psychologists who, by the way, I think are way underrated. I love the pain psychologists we have. My daughter is a clinical psychologist in training right now. I think they're wonderful. But we have to understand that pain is not just going to be fixed by a pill. It's going to be a combination of factors. So a lot of our education has been really around chronic pain treatment as well as safe opioid prescribing. We have standard guidelines for treatment for opioids. Certainly we've given our physicians many, many tools to try to do the right thing. Decision support in our electronic medical records doesn't only include how to prescribe appropriate doses for shortest duration, but also has all the other specialists, referral options, other treatments that can be used for a particular pain syndrome. So even at the point of care, you're reminded exactly of all the other things that you could do for that patient if you didn't already do it already. We've also augmented the specialists and the services that we want to have to help patients with chronic pain. Over the last 6 or 7 years, that's been significant. the resources that we've internalized, so that all those services are under one roof in our medical centers, so people don't have to have that barrier to access. It's difficult to get outside to go somewhere if you don't have a car, for example. But if you're at the medical center and it's all in one place, you can get there.
Yep.
So we've had a lot of internalization as well.
Let me ask you a question. The previous panel talked about the role of insurance companies. And I've often heard from physicians and prescribers saying, I want to do the right thing and not prescribe an opioid, and look at giving folks physical therapy, acupuncture, and often have an insurance roadblock. That insurance doesn't cover those kind of non-pharmacologic pain management strategies. So has that been an issue for people in your practice in terms of reimbursement for those?
So again, I'm lucky to practice in a setting where we have those internal resources, but I totally understand. I have friends and family that are physicians who do not practice in a setting like I do, and they have to be very cognizant of what that patient has as far as their benefit. So they may want to give them certain services, but they know that patient's not going to do it because they have to pay out of pocket for it. And that's one of those flaws in our healthcare system. We really need to expand the services for everyone in all lines of business for all of our healthcare plans.
Thank you. One of the things that many of you mentioned and the previous panel did too is, and I think with kind of many diseases and many people, the role of personal stories and personal narrative has dramatically changed the way that we see people. It's not a disease about us and them, but it's all of us. So maybe for anybody, Jim, Chief, Erica, what do you see as the role of people with lived experience in this? Either people who are still using, people in recovery, kind of parents who've been affected by this. Kind of, how do we use those stories to kind of change public opinion and public policy?
I'm happy to take a brief shot, Michael. We talk about this within Facing Addiction, and I'm being a little euphemistic, but we talk about this as an illness that no one's ever going to get, no one ever has it, and then no one ever had it, except for about 40% of all households in America. And clearly the statistics don't put us over the edge. Stories will. Stories will. It's stunning. I got here late last night. I went to a little restaurant near the hotel, and it was empty, and the server asked me why I was here. I told him, and within minutes he told me, 30-year-old guy, lost 10 years of his life, nearly died 6 times, but he's on a great course. This morning I needed somebody at the hotel to help me print stuff out, and a sweet little woman who just looked exhausted saw that, and she said, are you going to go to this thing? I said, yeah. And she said, I haven't seen my boy in 10 years. He's been addicted to heroin, and don't know if I'll ever see him again. I mean, this thing's all around us. Everybody knows somebody, and if they're honest, they're probably related to somebody. We still don't talk about it enough. We don't admit it enough, but we're going to get to a point where it's going to be more than half of the country. So it would be better if, as President Clinton said, if we just kind of got over it and got to work.
So let me talk about this, though. Congressman Cummings talked about the kind of untapped potential for people in recovery and people who've been affected by this. And maybe Jim and others could talk about the role of people in recovery can play in terms of either changing people's opinions or as it relates to advocacy. And I'll open that up.
Well, I was going to say one of the things we're trying to do in Cincinnati Hamilton County is use peer mentors. We're trying to, many in the treatment world are training people who have been there, who have done it. It's one thing for me as a cop to say I care. It's one thing for me to say I'll get you help. But it's another thing for someone who's been there and has experienced it. I would think that one of the long-term goals would be great is we have crisis intervention teams that go out for the mentally ill. It'd be amazing to have peer mentors that would be like a crisis intervention team that could go out to the street. An officer could call up, they could come out and hopefully walk them through that process. It's one thing for me to say I can get you help. It's another thing for someone to say, I've been there, I've done it, look where I'm at, let's go. So that would be great if we could go that way. That's one of the action steps we could be taking. We're looking at in our area and hopefully keep our fingers crossed it's something we can work out.
I just want to mention I use stories often when I teach physicians, specifically post-op care with surgeons. There's a few of us have stories where we may have seen a patient who's an adolescent or a young adult who had an athletic injury in a sport in college or high school. And as a result of that, they were put on opioids for a while, maybe longer than they should have. And maybe they held on to those after they were done and kept them in their drawer. And And then when there was a party, and a few weeks later or a month later, and their friend said, "Hey, you got some oxys? Let's go. I see that in your drawer. Let's go get." And then that leads to someone having an overdose, and that's how it starts. So, prescribing too much, more than a patient needs, especially young adults, college age, it's 61%, I think, of the reports is wasted, kept in a drawer, basically, and that leads to trouble. So I use those kind of stories a lot.
Erica?
Yeah, I was really pleased to see in the report the kind of inclusion of first responders in necessary groups to engage around this crisis. And I guess I would also say, as we're talking about stories and we're talking about inclusion and we're talking about kind of where we draw wisdom and ways in to communities most impacted by this, is that it is necessarily led by folks who have had this experience. I mean, the evidence that we're talking about is being borne out in their experience, in their work with one another. And it's really incumbent on us to listen into those spaces and to figure out how we can work in synergy with what they're doing. I mean, yeah, that seems fundamental to me.
One of the things I think we've been talking about in the previous panel is the role of advocacy, right? And I think, one of the things that I think really changed the trajectory of the HIV epidemic was, quite honestly, a bunch of really angry gay men and lesbians who said, we're not going to take it anymore. And really created, I think, the urgency around this. And I think many of us who've been doing this work have felt like this has not had the urgency that whether natural crises or other epidemics had. So, maybe you could kind of talk about, the role of advocacy and how we think about harnessing that kind of potential for really accelerating change.
There's one thing I was going to say. Look at Mothers Against Drunk Drivers. Right. It was a group of, excuse my language, pissed off moms that affected change. And I sit there across from parents who've lost their child, and there's many people who want to help, but there's not this big, large organization like a Mothers Against Drunk Drivers. It'd be great if there was this community grassroots that grew into a national level of mothers, fathers who lost their children and could advocate that, not just so that the public changes their image of the user, but also advocate for policy change.
Well, I couldn't agree more. When we looked at the addiction landscape, there are a lot of organizations with good people in them doing good work, in fact. But for complicated reasons, no one ever built a movement, created a critical mass. And frankly, all these things we're talking about as we look to government, and by the way, though, we shouldn't really rely on government to solve this problem, because government doesn't solve any of these problems. It can help. It can help. But in any case, nobody's ever built a movement in this space, and without advocacy and some anger and people putting pressure on their elected politicians, none of this stuff is going to happen. And Greg Williams and others on our team who are vastly smarter than me saw that. And so far, in 2 short years, we've stitched together something like 700 organizations. Some are kind of mom and pop, some are relatively big. They in turn represent like 35 million Americans. And we're learning, and they're helping us understand how we can turn that switch, how we can get them to write letters, how we can get them to get angry with a short fuse. And it's going to take a much bigger group, and we're going to have to become even more cohesive. But that's going to be the answer. We've got to get a large group of people saying, it's time for this stuff.
Erica, do you want to?
Yeah, I mean, there is a movement, and it's I look at the work that my colleagues in harm reduction are doing and have been doing. They've been doing the work that many of us have resisted doing until it got closer for us. I mean, and I think in that way, the frame that really lends itself to this issue is that this is yes, of course, it's a public health issue. It's also a social justice issue. Very, particular. I mean, there are circumstances that make particular people more vulnerable to drug-related harm. And, you know, in this way, it's an incredibly intersectional issue, and I think that we are going to gain an immense amount of strength by being able to find our ways into alliance with other movements. I mean, this is very much a racial justice issue. This is very much an issue for folks who have, you know, experienced trauma and gender-based violence. This is very, very much an issue about poverty. And, you know, and we cannot divide the public health response from the social justice response. And so addressing all these intersecting oppressions is going to be really, really critical to ensuring that we can, you know, that we're ready for the next time another crisis happens. I mean, until these core circumstances and such are addressed, we're not going to make a move on this.
Carol? I just want to say I think physicians were called to this movement, even if they were living in a cave. They figured it out about 6 or 7 years ago when the data for increasing opioid dispenses in this country was directly correlated with increasing deaths from opioids. And then statistics such as 99% of the world's hydrocodone is in our country, where we have 5% of the population of the world. So things like that made physicians engaged and listen. But honestly, the government has helped us, has assisted us by passing mandatory continuing education credit that is necessary in some states, many states. Also mandating, we mandated before they did, but mandating prescription monitoring program access, mandating a few other things like even prior authorization. Believe me, I hate having to fill out a form, but and so does everyone. Pretty much everyone does. That's a universal thing, I think. But when some states mandated prior authorization for certain doses and certain quantities of opioids, that did a lot to engage physicians that may or may not have been aware that they were doing something wrong before. So I think over the last several years, there's been a definite call to action, and physicians are definitely engaged at this point.
And I wanted to add something, because we were talking before about anger. And I told him a story. I gave a talk last week, and I said 50 to 70 overdoses, 4 to 5 people dying every week, and there was not a single gasp. But the other thing I need to say also is we need to figure out who we need to be angry at. Because right now we are angry at the wrong person. We're angry at the user because they overdose multiple times. But we're not angry at the dealer that I've arrested 7, 8, 9 times that gets out and puts fentanyl, carfentanil back on the street. We're not angry at a pharmaceutical company that lied to doctors, that lied to a society. Good. We got 2 angry people. We need you to be angry at them. Our anger is displaced in the wrong place, and if we put it where it should be, we could start fixing this. But we're angry at the wrong person. It's not the user. They have a disease. Their brain is infected by the substance. We should be angry at the people who did it for greed.
I love it when our law enforcement officers talk like public health officials. I think we've come a long way.
I'm hanging around you too much.
But let me ask this, because while we've seen great sea change among law enforcement, you know, I think all of us are worried that at the federal level, quite honestly, that despite kind of pairing drug policy reform with criminal justice reform, that we might be backsliding. So how do we keep that momentum going at the local level to really ensure that this is a health response and not a punitive response?
Well, I'm telling you, law enforcement is at a crossroads right now, because what I'm saying is not necessarily what the majority are saying. And there is a group that is pushing back and saying, wait a minute, this is a crime, I'm going to treat it like a crime. For us, it's unique, because we're arguing within our own realm, am I a law enforcement officer or am I a first responder? Right. This issue has blurred those lines, and even for us, we're confused. Me, it's no confusion. My job is to save lives, period. I don't care who you are or what you did. I am not to judge anybody's sin, because trust me, I have my own. So my job is to save lives. But we in law enforcement are arguing about what is our role. And this is where the public, and I keep saying this over, and I've been screaming it for 2 to 3 years now. It is you. You shift all policy that we, the federal, local, county, state officials do. And when you stand up and say, we're going to treat this differently, then we in law enforcement will have no choice but to treat it differently.
Jim?
Building on that, Facing Addiction has an interesting a program that we initiated recently we started hearing from a lot of communities that they're lost. They and it's not a criticism, they simply don't know what to do about this issue. So we created this pilot communities thing where we go in, and we don't have a silver bullet. We have some knowledge, we have some best practices that we can peddle around, and we bring together local leaders and healthcare and law enforcement, faith, parents, educators, and you get together and you start talking about what's working in your community, what isn't working, what are the gaps, because there are some similarities, but obviously depending on the makeup of the community, they're different. And we're working with them to forge a plan that we can leave behind so that within a year or so, they'll have some cohesive way to tackle this problem in their community and to either raise additional funding or redirect funding that exists but maybe isn't going to the best and highest use. There's nothing terribly glamorous about it or no magic, but it's just kind of rolling up your sleeves and getting to work.
I want to kind of follow up on the role of community, right? So many of you probably read the book Dreamland by Sam Quinones. Really great book. And I've gotten to know Sam over the years, and one of the lines that he uses that I steal from him, at least with attribution, is that the fundamental response to our opioid epidemic is community. And I think all of you who work in various sectors of community, and maybe just reflect on your own kind of thinking about kind of community and community coalition, kind of who needs to be at the table, what's really important for them to think about as they respond to this issues. I think all of us at the federal level, or used to be at the federal level, know we have a role, but ultimately it's what happens at the community level that's important. So I wonder if you could just reflect on kind of the role of community in this.
Yeah, I think when you say that, I think right away, I mean, my training is pediatrics and adolescent medicine after I went to pharmacy school. So I think of school and education, and in the community, in middle schools and high schools and colleges, how can my medical colleagues go out there and educate? And I don't mean just, do a lecture once, third period, and some kids don't even bother to show up. I mean, having consistent education in the schools that's required. I know all my kids are out of high school now, but I know that they were required to take a course in economics in high school. That was a requirement. They couldn't get out of that. They had to do it. Some of them thought it was, easy course. Some of them struggled with it, but they had to. But nobody was required to take a course on addiction or the substance use problem that we have in this country. And yet it affects every single child one way or another. They know someone or their family member. So getting into the community and educating and being there often, having standard courses, I think physicians and pharmacists as well are a great asset in this community, and they could be out there teaching.
It's a comprehensive community response. And when we started the coalition, the vision of the coalition came true about a month ago. We knew that it wasn't just going to be the 4 pillars of harm reduction, prevention, treatment, and first responders. It had to be every part of the community. It is a complex issue that needs a complex answer. So last month, I sat in this room, and for the first time in 2.5 years, we had almost every aspect of our community represented, from grassroots, the religious groups, universities, doctors, hospitals, elected officials, police officers, health departments. I looked in this room, I was getting emotional. I was like, wow, this is our vision. And it came true 2.5 years later. And when we talk about having the right people, the right organizations, it is everybody. And I will caution on this because I get this a lot, because everyone says you need to tear down these silos. I disagree. We should stay in those silos because those people are the experts in those silos. What we should be doing is we should have a door to each one of those silos that lets everybody in and lets everybody out, that connects everybody. Those silos are extremely important. I'm not the expert on health. I'm not the expert on treatment. I'm not the doctor. I need them to sit there and share the information, and I need to share it back. If we have that comprehensive community response, then we can make a dent in this.
Erica?
Yeah, I go back to kind of what I understand my charge as a minister to be, and that is in holding space and making space for folks. And as such, I think it is. It's again, I say it's incumbent on, I speak specifically about faith communities, to be able to breach the silence around this and, make make the statement prophetically that this is not an individual issue. This is a community issue. It's being felt, across all divides, and it does not occur in isolation. I think back to a dinner I had with some good friends who were here today, and we had the opportunity to, I think I had attempted to take a couple days off for a little soul care for myself, and found myself describing some of the struggles with work. And by virtue of hearing into our conversation, the one half of the couple sitting at the table next to us interjected herself into our conversation, and came to find out that they had lost their son about 5 years prior, had never spoken about it, did not know that there were people who were working to ensure that nobody else's child was going to die from an overdose, that there were people who cared about their child, who cared about them. And so by virtue of having these conversations, having these public conversations, being able to challenge, for us, there's some really well-entrenched theologies that are horribly problematic. And, so it's I don't know,
So we only have a few minutes left, and I want to end by just asking each of you, in the spirit of this conversation, and President Clinton's charge to let's think about actions going forward. Kind of from your perspective, you've all done an incredible amount of work, but what are the 1, 2, or 3 things that we really need to do next that we think is really going to continue to leverage change as it relates to not just this epidemic, but addiction issues in general? And Jim, I'll start with you.
Michael, I would singularly put stigma at the top of the list. I mean, these folks are all so smart, and you, not so much me, but we do know what needs to be done, but there's a little bit of inside baseball risk of smart people talking to themselves. I don't think we shouldn't underestimate the debilitating power of stigma. There's still half the people out there, give or take, do not think this is an illness, even though we've known it for 75 years. And if you don't think it's an illness, then you do think it's a matter of moral failing, and it's your problem, and why should I care? I mean, that is a huge issue.
How do we get to them, Jim? We've all been having this conversation, so
Sure.
How do we get to those people?
A massive education campaign, and it's I hope something that we will get to, Facing Addiction with the Clinton Foundation, but a massive, we call it a rebranding campaign, which is not to be confused with making this thing attractive. It's to reframe how people think about it as an illness. 90% of the people who suffer from addiction still never get any form of treatment. I mean, imagine if that were any other illness, there would be a riot in the streets. In my town, and you read obituaries of people under 25, and it's a sudden cause of death, a shocking, we know what that is. We know what that is. If people are not willing to face this thing and call it an illness, which is treatable, it's not inherently fatal, we can get there, but the first step is to get over the stigma and the shame and the discrimination that attaches to it. If we can do that, it's going to be a whole different ballgame.
Thank you. Carol?
I'd like to focus on prevention, I think, at this point. I think, at least from my perspective, I think that's where we have a lot of opportunity. Raising awareness in the community means, as I mentioned before, education. Again, my background is in adolescent medicine, peds. When we were all about antibiotic resistance, we went out there and we educated, we got the community involved. Patients realized this was not a good thing, and they went from demanding an antibiotic for a cold to saying, wait, do you really think I need that antibiotic because that might hurt a kid with a pneumonia? Do you really think I need that antibiotic? Yeah, this one you really do. We ended up just, the pendulum swung the opposite way with antibiotic resistance because we really did a great job at educating. And I saw that was actually mentioned in the report. And that was my analogy I was going to talk about today, but oh well. But anyway, it wasn't not a big thing. But anyway, we don't have that with opioid use. We have, as you mentioned, the stigma, and people are still expecting to get their opioids and be pain-free. And that expectation has to be changed through education.
Stigma. It is probably one of the biggest things blocking us right now, and I'll make this short. I hope within my career we shift addiction out of the criminal justice system into the medical health system. It should be allow us to go after the right people and allow us to get the right people the care they need.
I'm going to say stigma as well. I think it really is the core of this crisis, that as long as people who are created in the image of the most divine are redacted and fractured to pathologies and behaviors, it will not matter what strategy we employ. Speaking as the church, I mean, we have attached stigma and shame to the drugs issue and the people it touches. You know, we have in essence, as I said before, created a population of lepers, and it is incumbent on us to liberate them. We must be a space and a place that offers compassion and stands in awe at the many burdens that people carry, rather than judges them for how they carry it.
Great. Thank you. So, this is great. So in that spirit of stigma, I'm actually sitting here feeling a little bit disingenuous that I haven't talked about the fact that I'm a person in long-term recovery. And I'm one of 22 million people, and you know, I think those of us in recovery, I've often said, to the extent that we can, I do think that we have a personal responsibility to be very open and public about who we are, because that does change public opinion, and it does change people's minds. So I really want to thank our incredible panel today for the work that they're doing and for the work that I know that will continue to do. So thank you, everybody.
Thank you.
Thank you. Well, this just about wraps it up, and my name is Caleb Alexander. I'm co-director of the Johns Hopkins Center for Drug Safety and Effectiveness, and as I expected, those were two exceptional panels. Mr. President, on behalf of the Johns Hopkins Bloomberg School of Public Health, I'd like to extend our deepest gratitude to you and to the Clinton Foundation for your leadership and commitment to addressing the important issues that we have discussed today. 5 years ago, you mobilized the foundation to act, and since that time, you've been on the leading edge working for change, such as through the foundation's tireless efforts to raise public awareness of the crisis, as well as help people understand that addiction, as we've discussed, is a brain disease, not a behavior. I'd also like to thank Congressman Cummings, our other esteemed dignitaries, Dean Ellen McKenzie, and all of you who have joined us both here in the room and from around the country. Thank you for your participation. This event, as well as our newly released report, The Opioid Epidemic, From Evidence to Impact, took a lot of planning. It would not have been possible without the dedicated efforts of so many individuals from the Clinton Foundation and the Bloomberg School of Public Health, including those working to help communities fight the epidemic through the Bloomberg American Health Initiative. But as we've heard today, I too want to underscore the importance of the efforts of all of you in the room and all of you who have joined us today from afar. We've all been touched by this epidemic one way or another, and we should not doubt the power of our collective action. In 2011, Judy Rumler lost her son Steve to a heroin overdose. And I told her about this event, and I asked her if I could share his story, and she said, "I'm always happy to have Steve's story shared if it helps the cause." Judy talks about a note that she keeps next to his picture. It says, "If love could have saved you, you would have lived forever." Families shouldn't have to endure this suffering, and there's no conflict between reducing our over-reliance on prescription opioids on the one hand and improving the quality of care for those in pain on the other. But it is going to take effort and resources, and as you've heard today, mobilization. The good news is that we know a lot about what works. So thank you again for all that you do.
Hello, I'm delighted to wrap up today's event. My name is Andrea Gielen. I direct the Center for Injury Research and Policy. And on behalf of both of our centers, I'd like to add our thank yous to the distinguished panels of speakers who have both challenged and inspired us today. And to President Clinton, we want to sincerely thank you for all that you've done to address today's opioid epidemic and, of course, for being here with us today. Your leadership and the work of the Clinton Foundation, with its power to bring a diverse range of partners to the table, is responsible for putting life-saving tools in the hands of first responders, school officials, and health professionals from across the country. Today is the culmination of a long journey that, as you heard, began with the first town hall in this very room 3 years ago. And we're very proud to have been working in concert with the Clinton Foundation then and now as we continue in our determination to win this fight. Like many public health and injury problems, opioid overdoses reflect what happens when a product that delivers both benefits and harms exists in an environment that allows the harms to flourish. Addiction without access to treatment, too many medications from overprescribing, and medications supplied without its life-saving antidote are a few examples. Joined by the Clinton Foundation and a group of distinguished experts from around the country, we focused on finding the evidence to solve these problems. And our report, The Opioid Epidemic: From Evidence to Impact, was released today, and to provide that evidence along with specific recommendations for actions. The challenge we're addressing is how can we act collectively to turn around the alarming trends in opioid deaths so that the public is protected on the one hand and the benefits of proper pain control are delivered safely. We hope that today is the beginning of a new journey, one that moves us surely and steadfast to ending this epidemic. With the help of everyone here and everyone joining us online, we're confident that this goal will be realized, and we thank you all very much for being here today and for joining us in the future. Thank you very much. For those of you in the room, I'd like to invite you to the reception, which will be on the first floor in the atrium. Thank you.